only 2 slides. But diastolic heart failure is really about controlling a couple of things. It's not necessarily about mortality benefits or all those things we talked about with systolic. And it's more of a long life type of thing. It's an age-related disease that just happens. Usually patients have uncontrolled or not well-controlled hypertension throughout their lifetimes and just ends up causing this as a long-term side effect of the disease. So controlling the hypertension is the best thing we can do. So we're going to try and tackle that as best as possible. Tachycardia too, you can get some reflex tachycardia with diastolic heart failure because the heart's it's not pumping as much blood out with each stroke, so it's going to try and increase its rate to make up for that. So that can be something that ends up actually working against the heart over time. So if we can control the tachycardia effects of this specific subset of heart failure, reducing preload with vasodilators and diuretics. So we're getting fluid off, or we're dilating using broad spectrum dilators, either dilating the venous side and the arterial side, usually if we can. Any type of myocardial ischemia, if there's some sort of a repair, we can do surgical intervention. That would be an option as well. So pharmacology, we're using pretty much the same drugs. ACEs and ARBs do have a reduction in hospitalizations, improvement in class and exercise tolerance. Again, we aren't really talking about mortality benefits here. Beta blockers, calcium channel blockers, don't really have any literature supporting that they do a whole lot as far as quality of life things, but you do have some decent symptomatic relief that would come from lowering the tachycardic response, so people might feel better generally. So you think that they get some, but the literature is not as strong for those drugs, but most patients will be on them anyway. And digoxin has no effect or mortality on hospitalizations, may increase chest pain-related admissions. So we generally don't use DIG for these patients. Usually your core therapy is going to be ACE and a beta blocker, possibly a calcium channel blocker. So that's a big difference between diastolic and systolic. You can use the non-dihydropyridine calcium channel blockers like diltiazem and verapamil in these patients, whereas you wouldn't use those in a systolic heart failure patient. But otherwise, it's pretty similar. You aren't going to use DIG, you aren't going to use spironolactone, but for the most part, the core therapy is the same. All right. Acute heart failure. So that's kind of the gist of how we'd maintain a either systolic or diastolic patient from the outpatient perspective and what types of chronic therapy they're going to be on. Let's look at inpatient care. If you work in any type of hospital, whether it's got a cardiac focus or not, you're going to see heart failure patients. They're just a huge, huge area of readmissions to hospital, and it's very hard to control the disease to a point where your patients can be out of the hospital for good. It's just people tend to come back, and it's a delicate balance a lot of times with some of the drugs we're using. So patient education is really important to keep people out of the hospital. Medication compliance is really important, and we do a lot of work on the outpatient end trying to keep people out of the hospital by handling these problems as best we can with phone calls and frequent follow-ups and things like that. But at a certain time, we do get people to come back in. So there's some stats on here. It's an expensive thing. Lots of hospitalizations a year, lots of economic impact with heart failure. Usually your initial episode is about 20% of the admissions, and then about 79 of the other percent, if you look at like a yearly pool of admissions of heart failure patients, you'd see as repeat visitors. So again, readmissions are huge. And if you don't know much about how hospitals get billed, usually you have some core measures to meet. And if your patient gets discharged and readmits within a certain period of time, most insurance companies won't pay you for that readmission. So you're taking care of that patient for free. You're losing revenue for your health system at that point. So it's not only better for the patient, of course, because you don't want them in the hospital. They don't want to be in the hospital. But financially, it makes a lot of sense if you can keep them out. So that's why there's a lot of focus on investing money into good counseling, making sure that they're ready to leave the hospital the first time, not trying to rush them out. Because if they readmit, then you're in a troubling situation usually. We've talked about some of this as far as what drugs we're using to treat, but you've got salt and water retention, you've got decreased cardiac output, and then different reflexes causing neurohormonal activation. So your RAS system is ramped up, you've got your sympathetic nervous system ramped up. So that's primarily the drugs we're using, right? Our ACE inhibitors and beta blockers working against those two systems. We've got our diuretics that can help remove fluid and water. And then ultimately, by tackling this side of it, you're going to hopefully help cardiac output as well. So when it comes to acute symptoms, what are we looking at? Usually congestion and low cardiac output are the two major pillars here. And you can measure something called pulmonary capillary wedge pressure. This isn't something that's done like in an office or in an urgent care or emergency department. This would be, I think they have to use a special, I don't know if they use a Swan Scans or some other special type of catheter to actually measure this type of pressure. But it basically means that you're congested and you've got fluid backed up on the lungs. So the higher the pulmonary capillary wedge pressure is, the more fluid you have. Fortunately, you don't have to be a genius to figure out, well, you don't have to have genius level equipment to figure out if they're congested or not, right? You could listen to their lungs, get a history. You can usually diagnose this on the spot if you're familiar with working with heart failure patients. It gets a little tricky because if it's pulmonary edema, of course you could be looking at maybe is it a COPD exacerbation, is it pneumonia? But signs should point you towards the imaging and stuff should point you down this road. It might not necessarily even be pulmonary either. You could have pitting edema in the lower extremities. You could have ascites, hepatosplenomegaly, just maybe some appetite changes, early satiety, increased nausea and vomiting. Things like that would be common signs of congestion. And that's just being fluid overloaded. So stuff's just backing up. It's not getting through the heart, backing up in the lungs, backing up on the venous side of things. Low cardiac output would be the other side. This is going to be hypoperfusion. So usually you're going to see these types of symptoms. Cold extremities, hypotension are going to be the two big ones that you're going to see. And that's where things start to get really bad. If somebody's cardiac output declines severely, you're looking at progressing towards a cardiac arrest at that point. And those can be really difficult to get somebody back from that. So congestion, yes, it's a sign and symptom of advanced heart failure, and it can be acute, it can be problematic. But when it leads to low cardiac output as the heart starts to completely fail, that's where we get really concerned, and that's where people get into a lot of trouble. So cardiac output is measured in cardiac index. You have these numbers here. They aren't super important. Basically, for this class, I'd like you to know that you have different subsets, and so I think the names that they give them in quotes there are easy to remember. So you have warm / cold and dry or wet. So warm and dry would be a normal person, right? You're not congested and you're perfusing everything well, right? Your extremities are warm, not fluid overloaded. Cold and wet being the opposite. Your extremities are cold, you're fluid overloaded. So that's where we have the different subsets. One being a patient that doesn't really need anything. You could still have a mild exacerbation going on and be subset 1. Maybe you're just starting to get some fluid backing up on the lungs, but you aren't really wet yet. You're still pretty dry from the grand scheme of things. Maybe you just need a little bit of nitroglycerin, and we'll talk about where that comes into play here. Subset 4, of course, being the most serious, where you're very fluid overloaded. You're not perfusing. That's one step away from being a cardiac arrest at that point. Okay, so treatment options. Diuretics are going to decrease our fluid volume. So we're going to come back to loop diuretics here and talk about those. That's going to be our major way to get off fluid. Inotropes can help increase contractility, so they're going to hit the beta-1 receptor as an agonist effect, and you're going to get increased contractility. We usually don't want to mess with the rate of the heart too much, depending on what the situation is, but ideally you want something that's going to be an inotropic effect without really affecting heart rate or blood pressure all that much. Vasodilators and natriuretic peptide. Vasodilators can help reduce pressure and reduce preload very acutely. So if somebody's coming in and they've got fluid on their lungs, you give them a vasodilator, it can open up those blood vessels either on the venous and arterial side, help give you some more room for that volume to expand, thus alleviating some of the pressure and some of the symptoms a little bit. It's a temporary fix until you can get the fluid out. And we'll talk about all this in much more detail and what drugs we use specifically and what I mean by a vasodilator here. But let's go through the subsets. So I picked cats. I don't know. I put these slides together a few years ago, so I don't know. I must have thought cats was a good idea, but either way, you've got cats today. So if that helps you remember, great. If not, sorry, you can delete my pictures and put dogs in. All right, so warm and dry. Here you have good cardiac output, good cardiac index measure. And if you measured pulmonary capillary wedge pressure, it would be normal or slightly high even. So you're going to have a patient who is relatively stable. This is a decent heart failure patient. There's not much to do. What you can get is if this pulmonary capillary wedge pressure starts to dip down substantially. So you can see it's a little bit elevated over what we consider a normal. A normal person would be 8 to 12. A general heart failure patient, even stable, is probably going to be a little bit above that. They certainly could be in the normal range too. If you get them too low, that could be a sign of over drying and being dehydrated, and then you'd want to maybe fluid bolus them. But generally speaking, these patients are pretty stable. So for the most part, this is a situation where you don't really have to do anything. Just look at their meds, make sure everything's optimized and going well. Not really an acute situation, so it doesn't really fall into this category as well. All right, there's somebody who decided to bring their cat in the shower with them. I feel like that's a computer image, but it could be a real picture. I don't know. The cat's got a good expression on their face. Anyway, so warm and wet. So this is somebody who's perfusing, but they're congested. This is a really common presentation for heart failure patient. And hopefully they're presenting at this point, not when they're getting decreased perfusion. This is much more manageable, and this is an early sign of advanced heart failure. So if you go down the road further and start to accumulate more and more fluid, start to perfuse less, ideally if we can catch them here, get the fluid off, that's going to save us some work down the road. So this is a patient that's just congested. So really focusing on fluid here and symptom relief. So if somebody's got a lot of fluid on their lungs, IV vasodilators, as listed here, work really well in the short term. They're very fast onset. And again, they'll open up the vasculature, allowing some more space so you have more volume for that fluid to go until you can get it out. We like IV nitroglycerin the best. It's relatively inexpensive and it works really quickly. It also doesn't have a huge overall effect on blood pressure. Vasodilators will drop blood pressure. A vasodilator like sodium nitroprusside is super potent. It's also insanely expensive, which is a side note. But it's like $2,000 for a bag. It's crazy. But the point is that it'll affect hemodynamics a lot more than nitroglycerin. So if you're thinking you want to go into cardiology and you want to be on the acute side, or if you just want to learn for my test, whatever way you want to picture it, IV nitroglycerin for a warm and wet patient is going to be your first thing you're going to go to. It's going to relieve their symptoms. It's going to get them comfortable. It's not going to improve mortality. It's not going to get the fluid out. It's not really going to do anything other than make the patient feel better. Because IV diuretics, loop diuretics, Lasix, BMX, I should have used my trade names here. So furosemide, bumetanide, torsemide, those are going to take some time. Usually, even if you give an IV bolus of a loop diuretic, you're looking at probably 30 to 60 minutes for onset. So if your patient's looking like a congested patient with a lot of fluid on their lungs, crummy cough, maybe they're desatting in front of you, you can give them some IV vasodilator, nitroglycerin, get them comfortable, hopefully keep their sats up, give them some IV diuretics, and then keep that vasodilator going until that diuretic can kick in and start to remove some of the fluid. So that's usually the strategy with these. It's relatively straightforward. But the kicker is, and I've heard this from a lot of med students and various APPE students, or APP students that come through, is the docs will always say, okay, I've got a heart failure patient here, they're wet, they're congested, what should we do? And they're always like, oh, diuretics. And it's like, yeah, that's right, but what else? And that's where you always get stumped. Don't forget about the vasodilator, that's an important part. All right. So, vasodilators, what do I mean by these? And let's get into them just a little bit more. So our wet patients, our congested patients, nitroglycerin is a drug of choice. What it's going to do is form the free radical nitric oxide. It looks like this. And that just causes smooth muscle relaxation or vasodilation, decreases preload. We're going to talk about this during acute coronary syndrome too. Nitroglycerin is the same thing people put under their tongue. They're going to feel like they're having chest pain. We just give it an IV form. You could do the under the tongue, the sublingual too in this situation if they weren't really that symptomatic, but the IV is going to work a little bit faster than that. And you can titrate it. So if you give somebody something under the tongue and their blood pressure tanks, you can't really do anything about it because you've already given the medication. got an infusion going, you can turn it on or you can decrease the rate, and that'll get out of their system quite quickly. They'll metabolize it, and there's not a lot going in because you're continuously replacing it. So IV is a little bit easier to control. Nitride I've never seen used for like a subset 2 patient. It's just not done. I think they use it more for the more severe episodes, but somebody who's generally looking okay, a little bit congested, a little bit fluid overloaded, probably not a nitride candidate, but it is something you could use. The effects are similar, but it's got a lot more, I don't know if I'd call it, potency is probably a good way to do it, but its mechanism is slightly different. It just affects both the venous and the arterial side much more substantially. Whereas nitroglycerin seems to relax kind of right around the coronary arteries and the pulmonary vasculature. It doesn't really seem to affect systemic circulation as much as something like nitroprusside does. Nitroprusside is one of our most potent medications we can use to drop somebody's blood pressure really quickly. So it's just something, it's a tool in our chest for this, but it would be situationally useful. It also causes cyanide toxicity because that's part of the molecule, which is why I included the structure here. It releases cyanide ions. And you can handle a certain amount of it. Your body can process a certain rate, up to a certain rate, and there's no real risk for it. But we actually combine it with something called sodium thiosulfite, which is not important to remember, but it's a product that helps neutralize cyanide or helps your body process cyanide more efficiently. So it eliminates the need for that risk for toxicity. So if you're seeing that, you're like, why would you give somebody a cyanide drug? Well, we mitigate that with other strategies. And then there's Nasiritide or Natracor, which is a not super common medication. It's also extremely expensive. And it's a recombinant drug, so it's a biologic product that is basically synthetic brain natriuretic peptide. So what you get is smooth muscle relaxation. It's a different mechanism that binds to specific guanylyl cyclase receptors. And so it's not like causing a nitric oxide or type release like these other products are. So it's a little bit different of a mechanism. Some patients might respond to it better. Came out a few years ago. Abbott's a big heart failure center, so we used it a lot and did a big study on it, and we didn't find great outcomes with it over time. It does have some situational uses, but its use has kind of fallen off a cliff. Which, if it's not helping people, it's probably a good thing. All right, so cold and dry. These people are perfusing, but for some reason they're not fluid, or they aren't perfusing, and for some reason they aren't really all that fluid overloaded. So the question is, what exactly do you do? Well, this could be a heart failure patient who is dehydrated. Maybe they started to get some weight gain at home, and they took some extra loop diuretics to help get that fluid off, some oral ones, and maybe they got dehydrated and their heart failure continued to progress despite getting the fluid off. You could imagine scenarios like that, but the point is it's cold and dry. It's probably one of the more rare subsets you're going to see. But here we're focusing on the heart side of things, and not necessarily the fluid side. But you do have to make sure you have adequate filling pressures before you do anything to the patient. If you try and increase inotropic effects with a fluid down patient, you can do serious damage. So you really have to replace fluid. It's a little bit counterintuitive because you usually think heart failure patient, you don't need to replace fluid. Well, in this case, you actually would want to do that. So replace your fluids. This is going to be a case where you would actually use some fancy Swan scans or whatever they're using to measure pulmonary capillary wedge pressure and make sure you're titrating that to the appropriate effect. Otherwise, you could, again, do some damage with your inotropic agents. So two choices here as far as inotropes go. You can use pure inotropes, which would be dobutamine or milrinone, which I've got down here, or you can use dopamine, which has vasopressor effects in addition to inotropic effects. The difference being what their blood pressure is. So if their blood pressure is low, if their MAP is below 50, you're going to do dopamine, which is going to increase their blood pressure and cause contractility. If their MAP is, this is a typo, sorry. This should say MAP above 50. My bad. Yeah, I realize those are exactly the same. I'll change that on this thing. There we go. So if their MAP is above 50, you don't need to worry about their blood pressure, and you just want to focus on the inotrope alone. So you want to help with contractility. If their blood pressure is good, you don't really want to mess with it. Let's see. Anything else? We'll talk about inotropes here in a second. I think on this next slide. All right, so if somebody's hypoperfusing, generally speaking, these are the two drugs you're going to use. Dopamine is, again, an option for hypotensive patients. But dobutamine and milrinone are the two ones you could think about, and there's some nice use for both of them, I think. Dobutamine is probably the more common one. It's a pure beta-1 agonist. So it's a positive inotrope and chronotrope. Its half-life's really short, so you can give it as an IV continuous infusion and titrate it and get it to effect, and then you can also take it off quickly if you overdo it, which is always nice. It's a short-term fix. Usually you're looking at possible increased mortality benefits for using more than 72 hours. The question is if you need dobutamine for more than 72 hours, is your patient in a bad situation to begin with? Probably. And if you've worked with heart failure patients, maybe some of you guys here have been in that area, you might know that sometimes people are on dobutamine chronically as an outpatient. So one of the situations people can get into when you're really advanced heart failure, you don't have a lot of options, and you're responding well to dobutamine, is sometimes you'll be in a chronic dobutamine infusion to provide that constant inotropic support. People might actually go home or go to like rehab or nursing home facilities with that going around the clock. So that is a strategy we can do. Those people are very close to either, not to be all morbid, but they're either close to their heart completely failing and death, or they need to be transplanted, or they need some sort of a ventricular assist device. So that's a last-ditch effort. But thinking right now, dobutamine would be a short-term fix for inotropic support, but I just want to bring that up because you can use it long-term. It's just a bridge to something else. You can't do that forever. You have to either transplant the person or you put in, do you guys know what VADs are? Ventricular assist devices? Some people don't. It's basically a pump that you screw into the heart, and it has a battery pack on it. And it's a continuous circulation of blood flow. So people with a VAD are getting blood flow, but they don't have a pulse. It's kind of an interesting thing. So that's a bridge to transplant. Some people will be a VAD for the remainder of their life, but if they aren't a transplant candidate, for example. But most people, it's like they get a VAD and they'll wait for a transplant. Milrinone is another drug that does pretty much the same thing dopamine does. However, the nice thing about it is it works on a completely different mechanism. It doesn't work on the beta receptors. So that's nice because these patients are likely going to be on beta blockers. So somebody comes in to an emergency department in a hypoperfusing situation and they just took their 25 milligrams of carvedilol that morning. That could be a problem if you're blocking the receptors you're trying to agonize with the dobutamine, right? So that's where milrinone can play a really nice role in treating those patients who might not respond to dobutamine. Theoretically, you can push enough dobutamine maybe to overcome that, and it might compete for the receptors, and if you give enough, you could maybe knock the beta blocker off of there. But if you aren't getting a good response or you're not happy with your response, milrinone's an alternative, and you could use them together too if you absolutely needed to. A lot of times people will be on one or the other. They're both effective. Milrinone's kinetics are different. It's got a longer half-life, and it's renally eliminated, so it might accumulate in patients with renal dysfunction. And you also have less ability to titrate it as effectively. With dobutamine, you can really dial it in because it's short half-life. If you overdose your patient on milrinone accidentally by doing too aggressive of an infusion right away, it's hard to take that back because you've got a longer half-life to deal with. Both of them pretty short-acting, so relatively speaking, they both work well for the same thing. All right, final subset, cold and wet. As you can imagine, this is just combining everything we've talked about. So you're going to look at your heart first. That's always going to be your priority. If you can't control the cardiac side of things, the fluid is a lower priority. You certainly want to try and start getting some of the fluid off if you can, but we want to make sure that we're addressing the inotropic issues immediately, because that's where that'll cause a cardiac arrest if that goes unchecked. So it's really the same thing as what we just talked about. Your MAP parameters are the same, inotropes are the same, and then you're usually adding an IV vasodilator on in a lot of situations. And then, of course, later, once you get some things under control, the patient might look stable, then you might want to look at, okay, where's their pressure at? What's their fluid status? Do I need to get some fluid off? Do I need to send them to acute dialysis to remove a lot of fluid at once? Those are options too for these really severely ill patients. So there's a number of things you can do, but it's pretty much the same as subset 3. You're just adding that vasodilator on. Sometimes you might not really need the inotrope either. Maybe somebody is cold and wet, but things are looking okay, so they're just kind of on the borderline. So we looked at this chart, right? Let's say, what if you're right in the middle of it and you're kind of maybe a little bit on this side, but not quite there? Well, you can do a little wait and see and try and do some vasodilation, get the patient comfortable, get the fluid off, and maybe that'll improve things as it goes. So there's spectrums within these, but generally if they're cold and wet, you're going to focus on the cardiac side of things first.
Saying you do add a vasodilator with these folks?
That would be something you would likely consider depending on what their symptoms are, but usually you're going to focus on the heart side first. They can be somewhat antagonistic if you think about it. One's affecting chronic inotropic effects and the other is maybe having some vasodilation. So not really, but they can mess with hemodynamics a lot. One might increase blood pressure a little bit, one might decrease blood pressure. So it's a balancing act. I think what you want to focus on is where's their blood pressure, how hypoperfused are they, and then you direct your therapy that way. So if you can get them controlled on a dobutamine drip and they're improving and looking better and their blood pressure is stable, but they're still feeling congested, maybe they're still short of breath, then maybe you add the vasodilator on. And then you'd go to diuretics to get some of the fluid off if you needed to. Yeah. Well, that would be if for some reason they're cold and wet, but their hemodynamics are looking good. Maybe their heart rate's looking normal, their blood pressure's looking okay. It's like from a monitoring perspective, there's no real reason to give them an inotrope. At that point, they might just be slightly hypoperfusing due to the fluid potentially. So it just depends on how the patient's presenting and what your vital signs are looking like and your labs are telling you. So it gets a little complicated again because you can be on the middle of some of these.
Yeah. So let's say you start with the
likely, yeah. It depends on how they're responding though, because if you try and wean them off the dopamine and they start dropping, what they might do is, this gets into a little bit more of like acute care, but you might try and wean them off dopamine, put them on dobutamine, and then give them something else to support their pressure. So maybe you try like phenylephrine, which is a pure alpha agonist, or norepinephrine, which are more common pressors. That dopamine drips usually aren't continued for really long periods of time. They're usually more acute. So yeah, eventually you'd probably try and transition to a pure inotrope, and then you could kind of support the pressure as needed. But yeah, initially dopamine would be a good choice. Okay. So any questions about the subsets, then we'll go through a few tips about what we do about the chronic medications when we restart things. Okay. All right, so optimal heart failure medications are important in these patients. And just a couple things to think about. So ACE inhibitors are usually okay to keep on board if you're aggressively diuresing somebody. So if you have them on a really high dose of a loop diuretic, you want to be careful with the ACE, and in fact, you may want to hold it. If you dehydrate somebody accidentally and they're on an ACE inhibitor, that can cause acute kidney injury. So there is that risk there, but generally the ACE inhibitor is okay. Beta blockers, we aren't going to really do much unless they're hemodynamically unstable. So for the subsets of patients who are going to have low blood pressure or maybe even bradycardia, so if they're really looking on that cold end of the spectrum, hypoperfused, and they're kind of on that advanced actual heart failure pathway, we want to make sure we're holding that beta blocker and waiting till they're stable, then you can restart it. Not really going to do anything new with a beta blocker or change it until the patient's volume status is. So that might apply in the situation like a patient comes in and maybe they're just on a suboptimal beta blocker dose. And like, well, it might help their heart failure if we could go up on the beta blocker, but maybe they're fluid overloaded. So you wait until you can get some of the fluid off, stabilize them that way, and then you play with the beta blocker. Point is, most of the time with beta blockers, we're just going to either do nothing with them or hold them, depending on the acuteness of the situation. Digoxin usually doesn't have a reason to stop it. Some people can have withdrawal type symptoms, and I use that word loosely. It's more like rebound heart failure type symptoms they might get if you take their digoxin away. And there's not really a problem with having it on board in a lot of these situations, and unless their level's really high and they're toxic on it, that would of course be a reason to hold it for a little bit. But for the most part, you can keep it going. Okay, I want to talk about pulmonary hypertension for the last few slides. Anybody have any questions about heart failure? Pulmonary hypertension is kind of like a subset of heart failure, but review items. All right, so a caveat with pulmonary hypertension is it's kind of a rare disease, and you probably won't see it unless you work at a hospital that specializes in that. So like University of Minnesota Medical Center has a big pulmonary hypertension program, and most patients will get sent there to Minnesota. So even though my hospital, Abbott, has a huge cardiology program, we don't do a lot with pulmonary hypertension. We can take patients, and we do for like surgeries and things like that. But for chronic maintenance therapy, they're going to be at University of Minnesota mostly. That's a big center around here. So it's not super common, but it's kind of an interesting disease. The drugs are, I think, interesting and different. So if you're not getting pulmonary hypertension and it seems confusing, it's not going to be a huge part of the exam. I might ask a question or two, and they're going to be pretty straightforward. It's not going to be, I'm not going to get into a ton of detail on it, just because most of you probably won't ever work with these patients. Realistically, it's a specialty area. All right, so pulmonary arterial hypertension is usually idiopathic. It can be familial related, so there is some genetic component to it. There are some secondary causes that are more unusual. So HIV, liver disease, connective tissue disorder, toxicity from certain medications or other exposures can possibly cause it. But usually you're looking at idiopathic causes. Symptoms is going to be very similar to what we'd think about heart failure patients. So dyspnea, exertion, fatigue, chest pain, possibly syncope and weakness. And you get impaired oxygen delivery to tissue, ultimately diminished cardiac output. So what exactly are we talking about? You're looking at increases in pulmonary arterial pressure. So what happens is the pulmonary artery gets increases in pressure, you get backing up of fluid, you get that artery tends to get hardened, and ultimately I think the statistics are if you get diagnosed with pulmonary hypertension and it progresses on a normal course, if you don't do anything with it, you'll probably die within a year or two. It'll just basically cause a really advanced situation of heart failure that comes on fairly quickly. You get right ventricular hypertrophy and a lot of other things that we maybe associate kind of with the general heart failure patient. So it kind of causes heart failure in a traditional sense, but the pathophysiology of why that heart failure comes on is totally different than like a systolic heart failure patient we've just talked about. So our goal is to improve quality of life and honestly to prevent death. These patients, before we had some of these drugs, there was not a lot you could do. But we have some interesting therapies now that are actually causing people to be able to live fairly normal lives with this disease. And a lot of these patients don't have all the pre-existing conditions of a typical heart failure patient. So a lot of these patients don't have long-term standing hypertension. They don't have metabolic issues. They aren't usually overweight. They might just be a relatively healthy person that has a genetic disorder or genetic history of this or something like that and happens to get PAH. So with that in mind, once you get them medicated to the appropriate titration of their doses, then they might do just fine. There's not a lot of comorbidities at hand. Functional class is pretty similar to standard heart failure. These are WHO functional classes in case you're curious where they come from. So you might hear, if you work with PAH patients, they'll say WHO class 1, 2, or 3, or 4. And we're going to talk about these drugs here. And I don't want to spend a ton of time on this, but this is just where things would fall as far as what drugs people would use. And you're probably looking at things being like, I've never heard of any of these drugs before. Or maybe we barely briefly mentioned things like eprostenol and treprostinol, but talk about them quickly here. So beta blockers are something we can use if you're tachycardic. Diltiazem is a drug that works well for these patients. If you're bradycardic, a lot of times they'll put you on amlodipine or nifedipine. Those drugs just seem to respond, or they seem to have a good vasodilatory effect within the pulmonary artery, so you can decrease pressure that way. One of the interesting classes here are endothelin receptor antagonists, and these drugs are very specific for pulmonary hypertension. They aren't used anywhere else, and they're really expensive. There's a lot of specialty pharmacy, and obtaining them can be kind of tricky, but they work on these endothelin receptors, which ultimately prevent vasoconstriction within the pulmonary artery. They have a lot of side effects, They're teratogenic for women who are thinking of childbirth. You actually have to prove that you use 2 forms of contraception in order to be able to take the drug. You have to sign like a pledge statement and have a doctor sign off on it too, or a provider sign off on saying that yep, I agree with this person. They are using 2 forms of contraception. So this would be like a category X medication, a documented teratogenic medication. Both of them are. I think there's a new one too that I don't have on here, but anyway, it's not all that important. It sounds the same. They're really expensive, like $100 a pill isn't uncommon, but it's one of the only drugs that's useful for this particular disease. Usually insurances will pay for it if you have PAH. PDE5 inhibitors are phosphodiesterase 5 inhibitors, and these are probably more commonly known to you guys as the erectile dysfunction medication. So Viagra and Cialis actually have rebranded versions of themselves because I think people who are taking these medications don't want to be like, oh, I got to go take my Viagra, because of course there's interesting social stipulations with saying that. Or being on that, or seeing that in a medical bottle or a medicine bottle, but they rebranded themselves Revatio and Adcirca. And they're taken a lot differently. So like for erectile dysfunction, you take one once a day or a few hours before. But with these, you would do 3 times a day or once daily, and a lot higher doses, generally speaking. So people taking these medications, it's really easy to see if you're looking at a med list. You see somebody they're on sildenafil 3 times a day. That's obviously a pulmonary hypertension. They're it's taking really high doses of ED meds for that reason. So increased intracellular cyclic GMP concentration results in pulmonary vascular relaxation, which is the same basic way why they help to cause erections. They increase the body's ability to work with nitric oxide and cause vasodilation. And they happen to work in multiple areas of the body, not only in the genital area, but also in the pulmonary vasculature and also other places too. They cause headaches and flushing, so they have a more profound vasodilatory effect just in certain areas of the body. So this is a drug that we'll see people on quite often too, one of these two. There's not really a benefit. The tadalafil is once daily, which makes it a little more convenient. And then prostacyclin therapy. So these drugs are generally infused directly into the pulmonary artery. Most pulmonary hypertension patients will have a port in their pulmonary artery called a Hickman, which is a catheter that usually has a port somewhere up here-ish, and it kind of snakes down. I think I have a picture of it on the next slide. But these drugs are via continuous IV infusion, and they are given via pump, so people will have a pump with them. The new ones are kind of the size of like a diabetic insulin pump, and they have a little cartridge on them. The old ones were bigger, and they actually had to be refrigerated. So epoprostenol came out as the first drug here with Flolan, and so patients would actually have to light protect their pump, refrigerate it, and carry like a giant fanny pack around with them. The new drug, which we'll talk about on the next slide, is a lot better. You might see this if you work in advanced cardiac medicine. You might see people using epoprostenol or Flolan or Velitri post-cardiac surgery. People sometimes post-cardiac surgery tend to get a temporary pulmonary hypertension situation. So we give them like a continuously nebulized version of this for a couple of days post-op, and that seems to alleviate some of those symptoms. It's not something chronic or long-term, and it wouldn't replace the IV infusion for a pulmonary hypertension patient. So that's an important distinction. If you work in an ICU that's doing cardiac care and you see respiratory giving these chronic nebs, it's technically for the same thing, but think about it as an acute thing versus a chronic thing. They did come out with a nebulized version of this that is a home nebulizer, but you have to take it like 6 to 9 times a day, which no patient's ever going to be compliant with, so it didn't really do all that well. And here's the Hickman. It's a kind of a version of it where this is actually snaked out. A lot of people will just have a port that's kind of flush with the skin right locally there. Treprostinil or Remodulin is the new one, and so again, here's a Remodulin pump, and here's a Flolan pump. So a Flolan pump's not huge, but remember you have to have like an ice pack with it. The Remodulin pump is much smaller, and the cartridge that clips into it is really small too. It's a lot more concentrated. It also has a long half-life. So the thing about this Flolan is when people were taking this, the half-life 6 minutes. So if your pump malfunctions or if you run out of medication or something happens, you have possibly a few minutes before you could be in like a life-threatening emergency, which doesn't make patients feel all that good. So this drug with a 3-hour half-life, you can actually stop the pump completely. You can take it off. You could go swimming for an hour. You could come back and plug it back in and be just fine. So there's a lot of new functionality with these patients. And so, again, we're getting a lot better at providing more, I guess, lifestyle-friendly options for people with this disease. It used to be pretty awful, and I think it's getting not quite as awful. It's still not great. I mean, obviously, you don't want to have somebody infusing something chronically if you can avoid it. There's a lot of research in this area, I think, involving how do we get drugs into the lungs that are long-acting so we can just give people inhalers, because that's ideal. We give something through the lungs that goes straight into the pulmonary artery. So if you can do that, you're golden, but we haven't been able to figure out a way to do that conveniently. So that's why these IV infusions are still the mainstay of therapy. This requires, as you might imagine, an extremely high-functioning patient. Somebody who's not compliant or not adherent or has poor health literacy, probably not do very well on this. It's really expensive. A lot of times people are preparing meds at home, so they're like sterilizing a counter in their kitchen, mixing drugs together, making cartridges, keeping them in the fridge, dating them, making sure they have extras on hand. So again, there's a lot of maintenance involved with this that's really complicated. So just to keep in mind, I just think it's interesting. As far as an exam goes, I'd like you to be able to recognize a prostacyclin and a PDE5 inhibitor and an endothelin receptor antagonist. If you can do that, you'll be in good shape. If you can recognize those drug names and what they are, that's really all I care about with this. And that they're for pulmonary hypertension, of course. All right. Let's take a 10-minute break, and we'll come back and keep going with lipids and then anticoagulation. We'll get into that today as well.